Welcome back. Well, today I am joined by Dr. Daniel Sternfeld, who is here from Memorial Care. Hello, how are you doing today?
Excellent, thank you.
So we're going to talk about women who have gone through menopause and some of the gynecological things that they should be considering. Either they might be having some issues or things that we just haven't thought about. So give us an idea of whether or not we still need to visit a gynecologist after we have been through menopause.
Absolutely. Obviously, a woman's life is divided primarily into your reproductive years after puberty, and those primarily have issues with childbearing, getting pregnant, contraceptive preventing pregnancy. And then for most women around age 50 is when you go through menopause. That means you basically you have no more eggs. You're not going to be able to get pregnant anymore, and you experience loss of estrogen. So there are problems related to loss of estrogen. So even as a gynecologic surgeon, we're managing hormone issues, transitioning into a menopause, problems very commonly like vaginal dryness, which about half of women have. And then there are particular problems that are gynecologic that would be possibly managed by surgery. And a major one that we see in women is prolapse or falling pelvic organs. So, and this is more common among women who've had children, and there may be some stretching of the tissues, especially those women who've had big babies, but even in women who've had cesarean sections, you can have changes in tissues. And so some women may experience that, and it may begin even shortly after childbirth, where they have a loss of urine with coughing and sneezing, and then this can progress. So we see kind of an acceleration of some of that, where they feel bulging and perhaps in the vaginal area, a sense of pressure, problems with urine control. So that's a whole class of kind of surgery that we do where it may require surgery, and not always necessarily. Sometimes we have non-surgical methods to treat these problems, but that is sometimes where a surgery will come in place where we repair or restore the pelvic floor tissues. Then the other things that for women in menopause is more common, unfortunately, is certain kinds of cancer. So as women age, the risk of uterine cancer, ovarian cancer increases. Cervical cancer actually is a disease of a little bit younger women. It peaks in your 40s, but it still can be seen in women in their 50s and 60s. And that's why the more current recommendation for women who are approaching 70 and beyond who've never had a problem with a pap smear don't necessarily have to be screened for cervical cancer. But the other problems like uterine cancer, we treat. So that ties into problems where women will have bleeding after menopause, and a lot of those are benign issues that we treat. Sometimes they're treated with surgery. There are little polyps and growths, and other times, obviously, we have to screen and make sure someone doesn't have cancer.
So when you talk about all these different things, I mean, obviously the most important thing would be have your yearly check, because I would imagine that could a pap smear tell you about these kinds of things?
A pap smear is primarily designed for checking for cervical cancer. So absolutely, and cervical cancer can develop after menopause. It also can pick up, it's a time when you get infections, and also there's some sense of where a woman goes in there and you may not even notice it. You may have microscopic small bleeding. And sometimes a pap smear will show some cells that are coming from up higher from the uterus, even rarely the ovary, where you see cells that shouldn't be there. And we've had many cases of women over the years who the pap smear actually indicated not a cervical problem, but a possible beginning of uterine cancer.
Oh, wow. Okay. Now, what happens if you had some of these other things that you're mentioning, where you have some uterine issues? Is that something that you would be talking to with your gynecologist before they come in to see you?
Wait, they're asking the patient discusses
Yeah,
with me?
so if a patient is having the kinds of issues that you're talking about, for instance, where you are having trouble holding your urine when you're sneezing or coughing and things like that, would that be something that they would talk to their gynecologist about?
Oh, absolutely, yeah. I mean, most of those have to do with the base of the bladder. That's part of the pelvic exam. So we can see the support of the urethra and the bladder, and if there's damage and injury to that. And again, I just to stress for women, that doesn't always mean you need a surgery. There could be other issues. Sometimes we treat with medication. Some people have what's called an overactive bladder, where the bladder spasms, and that can sometimes be caused by medications you're taking. It could be treated by some other medication. So it's not always a surgical treatment. However, there are women, you know, with support of the urethra and the bladder, where we have these, it's revolutionary in the last 10, 15 years, where we have these little outpatient surgeries where you can put a little support under the urethra and you go home the same day, and it can stop urinary leakage.
Wow. Well, that's amazing, because it seems like a lot of women, that seems like one of the primary things that they do have issues with, you know, starting at some of the earlier stages of menopause. So what exactly is being done? That's considered a non-invasive surgery?
Well, no, it's a okay, minimally invasive surgery, if you want to call that. So for women that have, we call it stress and urinary incontinence, and that's most common. That's extremely common. Probably about a third of women have some degree, especially after having children, of some urinary incontinence. And for some women, it may be just an occasional thing, or if they have a severe cough, or, you know, laughing really hard, where, you know, they know those special cases and can maybe manage, cross their legs, or do something to prevent urinary loss. And some people, that's not a major problem for them. They can handle that. Then there are some women that it's a daily event. They have to be very careful. They don't want to soil their pants, so or underwear. So for that, the procedure for that type of incontinence is a little tiny. It looks like almost a little tape, a little tiny thing that we put just underneath the urethra. So it's a little incision you can't even see under the urethra, and we kind of place this underneath there and just press it against the urethra. So when you cough or sneeze, it's basically, if I was going to show my hand, if you cough and sneeze, it's dropping and you leak. So it's something that it's almost like a little hammock. It gently cradles your urethra. It's a little, and it's really very hard to even feel. If you put a woman examine herself, you wouldn't be able to feel it. And it just gives a little platform. So when you cough or sneeze, you don't get that big drop where you leak. And that's enough for most women where they won't leak anymore.
Oh, that's awesome. And then what about robotic assisted surgery? I would imagine that would be something more invasive.
Right. So now you're getting to robotic surgery, is kind of the revolution that started probably around 10 to 15 years ago. I did the first robotic surgery at Saddleback. It's been about 10 years ago or so. Now, the advantage of that, and that's used by other types of surgeons, it's used by urologists and even general surgeons these days, is the advantage of that was to put these tiny little incisions, either like 5 millimeters. So it's basically like a thick pencil-sized little tiny incision, and put several of these in the abdominal wall and hook this up to a robot, and then use that through kind of basically, you sit in a console. It's kind of like playing a video game. I put my hands in the little gloves and I can control this robot. So instead of in the old days where you'd have to open somebody up like doing a cesarean section, a big incision, you have to put a retractors in, put your hands in there and work in a woman's pelvis. And this way you put little tiny incisions, you use the robot to operate these miniature hands, and you can do, example, the common thing we do is a hysterectomy. So we can remove a uterus through little tiny incisions. It basically is turned a 2 to 3 day hospital stay into staying in the hospital for several hours and going home the same day. So where would we use that? For gynecologists, we use it for benign tumors, bleeding, things like that. It can be used, usually there's a separate, if someone has cancer, we have it at Memorial Care oncologists that deal specifically with cancer, and they can use the robot too in certain cases, because obviously if you have cancer, you have to check lymph nodes and check for spread, and that's best used as specialists who deals with cancer. So there are different specialists who use it. As a gynecologic surgeon, I'm primarily doing benign gynecologic surgery.
Okay. Now, are you located in the hospital, or where are you located?
My main office is adjacent to Saddleback, the Memorial Hospital in Laguna Hills, and the building adjacent to it. So that's primary. We have in our group Well, actually, Memorial Care has expanded now. So we have an office in Irvine, we have office in Fountain Valley and Long Beach, and even Rancho Mission Viejo down here in South Orange County again. So we're spread over here. But right here, my office is right across from Leisure World. Very close.
Well, we now call it Laguna Woods Village.
Laguna Woods, yeah. I've been here for 30 years, so I still remember the old name. I gotta get with it. Laguna Woods, yes.
That's funny that you say that. Most people, I tell them where I'm working, they're like, where? And I go, okay, Leisure World. They're like, oh yeah.
Right. That's where I've been here since the 1980s, so that's what it was back then. And it's probably, what has it been, 15 or 20 years now? It's been Laguna Woods.
It's been a while. It's been a while. Well, all right. Well, thank you so much. I really appreciate you taking the time. You know, something that we're all experiencing, women over 50. So thank you again.
Okay. Thank you very much.
All right. And we'll be right back after this.